Without taking much of your time, can you add the slides, please? We'll go to another innovative trial, which is the PRISM Registry. I wanted my colleague Dr. Anuj to be presenting this, but because he's occupied in the lab, I'm covering up for him. This is a prospective multi-center registry to investigate safety and effectiveness of Ensure as sirolimus eluting coronary stent. This is the objective of this registry is basically to assess the safety and effectiveness of Ensure sirolimus eluting coronary stent in patients with significant coronary artery disease. Then secondary objectives are following up these patients and seeing for major advanced cardiac events at 12 months and any evidence of stent thrombosis, either acute or late. The registry design is basically, it is a multi-center registry. We plan to include about 100 to 120 patients with clinical follow-ups at 1 month, 6 months and 12 months. And probably we have decided to have an angiographic follow-up around 9 months yesterday in the investigator meeting. I'm very thankful to all the participating centers which are listed here. Dr. Madhukar Shahi, our chairperson, is one of the investigators in it. And Dr. Suhas Haridas probably is a co-lead. He's also present here. Thank you very much for all for agreeing to be part of this trial. The registry population is real life patients. We are trying to exclude out as much minimal patients as possible so that we'll get a real world scenario. The most of the patients, but for the patients who are having instant restenosis or graft, most of the others are included. But the standard patient should be more than 18 years of age, acceptable candidates for other forms of revascularization. Obviously, they should be symptomatic. There also inclusion of CTOs and bifurcations. And then target lesion length should be less than 36 because maximum stent length is available was less than 40, around 40. And the target lesions located in the epicardial vessels of 2.5 to 4 stent lengths are like that. Exclusion criteria are pretty standard. Again, significant renal dysfunction is excluded, and any patient with platelet disorders and history of CVA, TIA are excluded. The known allergies for this drug and patients in acute MI or cardiogenic shock are excluded. Then, according to the angiographic exclusion criteria, only left main disease or presence of significant thrombus or a severe LV dysfunction. As I said, venous interventions are excluded. We wanted to avoid immediate post-MI also in one or 2 days. From day 3 onwards, the patient could be included. The various stent sizes available are mentioned here. It varies from 8 to 40 mm with the diameters of 2.5 to 4 mm. Then the major endpoints, I said, major adverse cardiac events at 30 days, and then death MI and emergency CABG, and clinically developed TLR will be assessed. Then immediate angiographic outcomes are the immediate pre and post diameter stenosis, MLD and restenosis. Then few words about this newer stent. Some of you must be wanting to know about the details of the stent. Basically, it's supposed to be having a strength and flexibility because they have combined a closed cell and open cell design together so as to have a better radial strength along with the flexibility. So you have areas in which closed cell and open cell designs are amalgamated. And then stent stud thickness is quite less, significantly less than the older versions of Cypher, almost comparable to many other newer ones. Then at the same time, the radial strength is not preserved because of the make of the stents. Then if you see here, the radial strength is comparable to many of the standard available ones. And the drug loading, it depends, slightly varies according to the stent lengths, which are mentioned here. I'm not going to details because of the paucity of time. And the drug elution kinetics, most of the drug gets delivered in about 30 days of time, where the chance of restenosis is maximum. And then this stent is even tested in the pre-animal models. We have histopathological studies available by Renu Virmani and others about this. And the polymer is, again, as we understand that most of the polymers, we are moving towards biodegradable polymers. This polymer of that has these characteristics, and everything gets degraded by about 40 to 50 days of time. Then lowest stent stud thickness with biodegradable polymer and limus-based drug, stent is supposed to be performing well. We have even high-resolution pictures for computer tomography. Then the endothelialization patterns are also studied in Renu Virmani's lab, showing that it gets endothelialized well. Then the balloon on which this is mounted again is a CE marked one and a pretty standard. Then this criteria for good stent implantation are like standard. Residual narrowing should be less than 20%. And then pre-dilatation is kept as mandatory because stent expansion could be in trouble if a lesion is not prepared well. The pre-procedure protocol of antiplatelet agents, basically aspirin and clopidogrel, pre-treatment is pretty standard. We also thought of, in investigator meeting yesterday, we thought of adding prasugrel also in this because some of the centers have switched over to usage of prasugrel. There was discussion whether newer coming ticagrelor could also be involved, but as of now we thought we could withhold that. And the usage of GP2B3A is left to the operator's discretion in this trial. All the patients will be kept on aspirin and a minimum of 75 milligrams of clopidogrel. Then after discharge, and these patients will be followed up for about 1 month, 3 months, and 6 months, 9 months, and angiographic follow-up will be done around 9 months of post-procedure, 9 to 1 year. Then any adverse events or serious adverse events will be immediately reported. The probable expected adverse events are related to drug, and some of the serious adverse effects are pretty standard, like stent thrombosis, hospitalization, death, or any significant other problem will be again immediately reported to data safety monitoring thing. And angiographic core laboratory, the one which we established in CARE, we are acting as central angiographic core laboratory for the analysis of the data pre-post. And we hope that all the centers would perform well. Maybe in next conference we would be able to show some of the results. I just wanted to briefly show, initially before we decided to do a trial, we wanted to see on some of the patients. This is a very tight stenosis in the proximal LAD. This is again immediately after this was 3.5 into 20 stent was used. The immediate appearance looks quite encouraging. This is another patient in which tight LCX disease was there. This is protected circumflex. Lima was filling the LAD. In this patient, we used 3 into 16 I'm sure stent, and the result was quite good. And hardly doesn't give too much metal appearance like older version of Cypher stents, and that's how we hope to have a good positive result.